We have a great webinar today, and I'm going to turn it over to Mark Brownstein. Thanks for being here, Mark.
Well, thank you, Liz. Thank you for the connection I have with this organization and the years in which I've participated and the number of people that I've met and helped and clients I've helped. And I love doing these presentations. I love doing them live, but the second best is doing webinars. And all of you are in the comforts of either your home or your office. And again, I am looking forward to adding value to the work that you do for your valued clients. The work that we do as a company, we have a staff of 7. And so it's not only I who participate and add value to clients. We've got over 3,000 clients. So I'm going to go through a presentation. And again, don't hesitate to ask questions. It's just harder to answer them on the spot as it would be if we were live. So that's the only comment that I would make. So I'm going to start out by just letting everyone know that we are aware as a company. I am aware in the thousands of phone calls I handle every single year that people are absolutely confused about Medicare, whether it be the timing of Part A, whether it be dental or co-insurance or penalties with Part B, and the impact of the IRA, but it's really the Inflation Reduction Act from the last administration. It's the big, beautiful bill from the current administration. But the big changes are around prescriptions. It's about deductibles and copays. So I'm going to cover all of that. But people do ask similar questions, but everyone's situation is different. And that's why I love what I do. We take the time to understand everyone's needs. So just so that you know, for me as a company, I've educated about easily 5,000 people. I do about 30 educational webinars and seminars a year, and we've got over 3,000 clients nationally. So we've been doing this. We're confident that we can solve most challenges. There are some doozies out there. But when it comes to Medicare or healthcare costs. And as CPAs, you're talking to them about general and specific costs and planning issues, but healthcare costs is a big issue for people. I always encourage them to make sure that it's being taken into account. It used to be current lifestyle was really important for financial concern around people's financial future, their retirement. But also, drug costs are really growing in terms of importance. And dental concerns raised the level of concern in ways that I'm always surprised at and will cover. But dental concerns are always coming up, and people don't necessarily need as much care as they do when they turn 65, as they do when they're under 65. So Social Security has had cost of living increases over the last 30 years. It's really been on the average about 2.3%. A lot of news is about that, and people talk about their raises they're getting from Social Security. But people who are on Medicare are paying for Part B generally out of their Social Security check. Certainly, some people just don't have Social Security, so they're paying Part B out of their checking account or in a check. But Part B premium increases over the last 30 years have averaged 5%. Well, between 2025 and 2026, the Part B premium went up 11%. So Part B premiums, again, not being talked about, but it is an impact on your clients. And then I'll talk about later this IRMA, this income-related Medicare adjustment that is going up as well. But in general, Part B premiums are going up faster than the Social Security increases. So I wanted to cover some of this information up front. And often I've put this in the back end, but I just want to address some common mistakes that people are making that we see all the time and people get really concerned and anxious about. On the left-hand side, you'll see missing Medicare enrollment deadlines. People are always realizing that at 65, something needs to happen. What it is that has to happen is really based on everyone's individual situation. But at the very least, many people will get Part A. Part A, hospitalization, generally premium free. But if someone has an HSA, a health savings account, and they like their HSA, then I encourage people not to even get Part A. But the fallacy in the industry with people who talk to each other about Medicare is that people feel like they're going to get a penalty for not getting Part A. That is absolutely not true. So the enrollment deadlines really apply to Part B. So let me say one thing additional, and I'll say it many times during this presentation, is the most important time to look at Medicare is for someone who is unemployed, self-employed, or working for a company of less than 20 employees. That's the key piece when people are at risk for making the mistake of missing a Medicare enrollment deadline. Um, and so there are people who are covered under a plan that is under 20 employees, and they figure they're fine because they are covered. They're over 65, but they don't realize that because they're under 20 employees, they have to get A and B. So the question will become whether they should stay on their group plan or they should go into Medicare based on family that might be on the plan, maybe other employees on the plan. That decision can change. The next common mistake is staying on COBRA too long before Medicare. So COBRA is not considered credible coverage. It is shocking, but it is true. So somebody who is retired, I want to be clear, somebody who is over 65 and retired, um, if they are getting COBRA or paying for COBRA because they need it for their family or for themselves, they still have to have Medicare A and B. And so this is a mistake that people make actually more often than you would think. People assume that COBRA is credible coverage. They are over 65 and retired. Maybe they're getting some kind of a post-retirement package. Maybe they're getting a lump sum distribution. Um, but the way around it, and this conversation comes up often, folks, is if people are getting a lump sum, it's very different than if they are getting a payroll check. If they're getting a payroll check, they can actually theoretically delay getting Part B. So when people are calling me prior to retirement and they're talking about Medicare and COBRA and their exit strategy, often I'm suggesting that people look towards not getting a lump sum or getting some payroll. But the bottom line here is that a mistake that's made is that people are on COBRA post work in retirement without having Medicare A and B. This is where there are penalties that, of course, nobody wants to ever think about penalties. The next bullet is not understanding the health savings account contribution rules. So people often love their HSA. It's a high deductible plan. They can contribute for themselves or for their spouse, and they can continue to contribute as long as they don't have Part A. So again, getting Part A at the time in which they are turning 65, which is what people will suggest that people do, is actually a potential mistake. Now, I have seen very few people ever get audited on an HSA contribution that they should not have made. But people want to do what's right, and those are the rules. So 6 months before one gets Medicare of any type, one is supposed to stop contributing to an HSA. There are some people who know they're retiring, and let's call it the second half of the year, and they contribute, they front load it at the beginning of the year. And so the timing of HSA, the value that an HSA brings, people also ask me the question, I just want to make sure, Mark, that I can use this HSA for years and years. So if you have 5, 25, 50 grand in your HSA, you're going to continue to be able to use it. It's just a matter of the timing of getting Medicare A and or Medicare B. So that's another common mistake that's made. So another common mistake is people often choose plans based on the premiums. Now, premiums, of course, are important, but I can tell you that premiums alone is not a strong enough factor because some of the premiums on some of the plans are higher, but they offer greater benefits. So people know that Medicare is sort of Medicare A and Medicare B, and then other things get added that I will cover. But the premium price is not an indicator completely of what you'll get out of the plan. The other piece of that is the carriers. The carriers will often start out low on their premiums. And once they got you, in some states, you can't change your plans unless you go through underwriting. So they will jack up their prices in subsequent years. I call this bait and switch. So one has to really look at the carriers, their history over the years. So some people want certain carriers, and again, it's really important for them to understand the long-term implications of choosing a plan based on premium. The other piece, the last common mistake, is ignoring provider networks and prescription formularies. So provider networks are constantly changing. There's a consolidation that's going on in this industry around provider networks. Um, where you are, you know that some of these organizations have brought in other groups so that they can have everything under one roof. And so these provider networks are changing, and some of the carriers are no longer accepting coverage for individuals because they are no longer in network. So it's important to be clear and continue to work with someone who can guide you because these networks change and carriers um, aren't always staying in there in subsequent years. Prescription formularies, the disruption in the prescription drug market has been enormous. It started with the Inflation Reduction Act, and I will talk about that more later, but the formularies keep changing. People need to understand that it's no longer a set it and forget it model with Medicare. So, what are the other types of mistakes that often are led to lifetime Medicare penalties? So, just talking with someone here today, and the client had a gap of 2 months that they had no coverage after age 65. Okay, even for those 2 months, there's a small penalty. But for people who don't get Part B when they're supposed to because they were working for a company of under 20 employees, these are lifetime penalties. It's 10% a year for every year that you actually didn't have Medicare. And again, it lasts for life. So the penalty, let's call the lowest possible cost for Medicare being $203 a month. 10% of that is $20 a month forever. If you're in a higher bracket, and we'll talk about that, then the lifetime penalty could be higher. That's a calculation that Medicare makes, but the lifetime penalty is something that people truly want to avoid. Coverage gaps. Okay. People want to make sure they're covered. People are concerned about certain procedures, certain durable medical equipment. They also are concerned that they are being let go the middle of the month and they aren't covered through the end of the month. So nobody wants a coverage gap. I've seen people who didn't want a gap of 3 days, right? And so you have to look at how long are you covered for when you leave your company, and making sure, in addition, that the coverages that you have cover you for situations and networks and prescription drugs that are important to you. So, unexpected out of pocket costs. We know that there is billing that takes place in this industry. People get bills that they don't understand. People often just pay those bills, and these are costs that sometimes are erroneous, but sometimes it's not about understanding your plan, right? So there are out of pocket costs that are deductibles. There are out of pocket costs that are copays and co-insurance. And then there's out of pocket maximums. So these are unexpected. People don't necessarily understand their own healthcare plan that they have. To the extent that people understand the healthcare plan that they have, it helps them understand a little bit more about how Medicare operates. Prescription disruptions. This has really been a major issue. Um, People will be prescribed medications in the middle of the year and they'll call and say, why is this so expensive? Well, it's a brand name medication. Maybe they need to talk to their doctor about getting a generic medication. And so these are disruptions to people and to their costs. Prescription drug costs are certainly evolving in this marketplace with the government. So small mistakes can create significant long-term financial consequences that, of course, you just want to be able to warn your clients about. So again, healthcare is becoming a major retirement risk. Today, consumers are facing rising healthcare costs all across the board. So one of the examples that I often give is that copay is a set amount. So you have a copay for an MRI and it's $150. Now the insurance companies are changing this to co-insurance. So let's call it 10%. So which is higher, a copay or a coinsurance? In the long run, the insurance company will make more money if they have a coinsurance dollar amount than a copay set fee. So those are changing. People are seeing this subtly. These changes subtly are happening because of this big, beautiful bill. And people are not necessarily going to react to this as we approach the midterms, but these are real and these are happening. And insurance companies are making changes unbeknownst to most people, which is why I do this education. So I mentioned earlier about narrower provider networks. They are becoming narrower, but the change that's critical is that there are less PPO options out there than there were even 2 years ago. So the PPO model in the world of Medicare allows you to go outside of your network, maybe for a little bit higher copay, but allows you to go outside the network. Those are going away all across the country, all across the board, even in plans that you may have now if you're working for a company. So the other piece is that now it's more HMO. Um, 25 years ago, PPOs came onto the market and everyone was um, clamoring for a PPO that they can go outside the network. Now that's being cut back. And most of the Advantage plans, which I'll cover, is now being restricted to just HMOs. There's more administrative complexity, though there's AI that's being utilized in many areas. That's either good news or bad news. There is certainly more administrative complexity. People are dealing with prior authorizations, they're dealing with claim denials. This is all about advocating for yourself, knowing very clearly that your plan should cover something that it's saying it doesn't. The truth is that less than 5% of the people out there actually advocate for a denied claim or a prior authorization that is denied. And of those people that actually advocate and appeal, over 50% actually win it. It's not easy. It's a challenge. We try to help people as best we can, but we're not the insurance company. And so we encourage people to advocate. We encourage people to not accept a claim denial right off the bat, or even pay the bill right away if it feels like it's wrong. So it's more responsibility for the individual client to navigate through this system themselves, and that's becoming more and more evident. No matter what part of healthcare you're in, no matter whether you're on Medicare or not. So why does this matter to your clients? Healthcare costs, again, as I mentioned earlier, healthcare costs threaten sort of income sustainability. Um, I think I have a slide here later or not, but about $400,000 is the estimate for people, for a couple in retirement to have to spend on healthcare in some way or another. That's a huge amount of money for a couple who has both gotten to 65, one of them is likely high percentage of likelihood of getting into their late 80s. So there's a tax exposure. So medical decisions sometimes trigger some tax consequences. that occur. And some of it has to do with the IRMA component, which I'll mention as well, which is this income related adjustment that has to be thought of years ahead of time because the IRMA looks at their tax return 2 years prior, the adjusted gross income. It's actually modified adjusted gross income. And so some of that is about planning between CPAs and financial planners to make sure that their decisions, even though IRMA is for higher income people, um, people consider it a penalty, even though it's a tax sort of. But the truth is people get upset by this IRMA adjustment. So asset protection, right? People want to protect their assets, but the healthcare costs can erode retirement savings. So it's really important to keep that in mind as people really look at longevity, look at their assets, and look at their financial planning. And then there's the caregiving cost that affects entire families' finances. I am actually a certified senior advisor. I've worked in helping people navigate through this healthcare system as a home health and nursing home and assisted living, and those costs are really high. Even if the burden is on a family member, there's still caregiving costs, whether they have long-term care insurance or not. Most people don't. So they're looking at retirement income in order to be able to afford these pieces. So again, I just mentioned that income adjustment. Okay, so if you look at this chart, you see that for a married couple or a single person, the lowest level is under 109. Actually, it's 109 and 218. That's a misprint there. So that cost is 202.90. And above that, you can see that the premiums go up pretty substantially, and there are many people who are your clients who are shocked by this chart. That's both Part B, which is the big piece, but also a bit of Part D. So the key here is that they have this higher income from 2 years prior. It's a 2 year look back. It's a surcharge. It means that people have exceeded certain income thresholds, but there is an appeal form. The appeal form allows them to estimate their 2026 or their year in which they retire if their income has dropped. Spoke to someone yesterday with RMDs. They're about the same level that they were. So at some level, it is what it is, but the opportunity to save on this through the appeal form, I'll cover in a bit, but this is the chart that's important. So the insurance carriers are reshaping coverages. They are claiming that their loss ratios have been tremendously impacted by this. Okay. So it's really post COVID care that they've been catching up from. And there's rising drug expenses that they are incurring. Why are they incurring drug expenses? Well, look at just the GLP-1 drugs itself. They are absorbing a lot of those costs, and it's changing the marketplace. Um, Hospital and outpatient costs. The truth is that these costs are going up in a big way. Doctors always talk about not getting raises, but the outpatient costs and the in hospital stays are just growing. The challenge is that because of the big beautiful bill, 30% of all rural hospitals are set to close. Without Medicaid money, these rural hospitals will no longer exist. So this regulatory and reimbursement pressure is consistently bearing on the insurance companies. I'm actually going to a presentation next week to hear more from a specific carrier on some of the regulatory and reimbursement pressures that are on their plate, so that I can communicate. Not that it matters, but at the end of the day, you can just look at their stock prices. There is no health insurance company or prescription drug company that is actually doing well these days. But the clients are going to experience higher out-of-pocket costs, narrower networks, more prior authorizations, formulary changes, reduce supplemental benefits on Medicare plans, and these elimination of these PPO plans. So, um, so the Inflation Reduction Act and the Big Beautiful Bill. The Inflation Reduction Act in 2025 or 2024, excuse me, implemented something that has been helpful to so many of our clients. The Donut hole no longer exists. But what they did instead was they had a limitation to the amount of money anyone can spend on Medicare for out of pocket prescription drug costs. That number used to be $8,000. Now in 2026, it's 2,100. In 2025, it was 2,000. So there's no more donut hole. The maximum anyone can spend is $2,100 out of pocket. That has changed the entire marketplace because the insurance companies realize that they have to absorb the difference that they had calculated between the 2,100 and the 8,000. And that is changing the benefits and the premiums for every plan that's out there, including plans that you may be on. Suddenly, these things are changing. The drug price negotiations started in 2026. There's a whole list of them, some of which I will show you, that are being negotiated, continue to be negotiated, very common named medications that people are spending a lot of money on. Even though there's a $2,100 maximum, people are still coming out of pocket for um, medication costs. The premium growth on these plans have been capped at 6% a year for Advantage plans and prescription drug plans, but not for Medigap plans. I have seen increases on the Medigap side of 20 to 30% around the country. But also, um, extra help, which is for low income seniors, has helped a little bit more in prescription drugs. Now, the big, beautiful bill, OB3, over $1 trillion in cuts in healthcare programs, and that's across the board. Again, it's Medicaid, it's ultimately Medicare, it's ultimately Affordable Care Act, it's ultimately group coverage. All of them are being impacted. So there's Medicaid work requirements. So a lot of the people that I work with are on Medicaid for the right reasons. But there's certainly a thought out there by the government that there are people who aren't looking for work. So there's a work requirement. The Medicare Savings Program is another program that exists to help people with Part B premiums. So again, if they're at 202.90, they're under 109,000, but they're way under that number. They can actually get help with Part B. And we help people, we can't sign them up, but we certainly help them with the form and being able to access that information and the limits that occur. So the Affordable Care Act premium subsidies have expired by the end of 2025. And so millions and millions of people are being forced off of these subsidies, the Affordable Care Act. A lot of people are then going to be going to hospitals. The challenge is a lot of hospitals are closing. Without Medicaid money, hospitals will not survive. There are parts of the region that we live, all of us here in the Northeast, hospitals are going to close unless something changes. But there are also automatic spending cuts. This is all from the bill, across the board reduction. So it's a flat 2% cut to Medicare reimbursements paid to healthcare providers. That doesn't make anyone happy. The providers are working hard, they have a lot of patients. As it is, it's hard to get an appointment with most doctors these days. They're overwhelmed. They're not necessarily taking new patients. So 11.8 million people are projected to lose coverage by 2034. Again, this is a 10-year plan. So this new bill, I call it OB3, this is a 10-year changes to drug pricing, etc. So households are going to see incremental but steady increases, with some areas facing double-digit hikes. But the insurers truly, folks, are in self-preservation mode. This is influencing policy changes that trickle down to consumers. Once the bill was passed, hospitals and facilities had to automatically make adjustments because they couldn't wait until the bill was impacting them. They had to make changes to staffing. So different regions are certainly impacted differently. Some have flat cost increases. Some areas have notable increases. But the impact is truly mostly felt in rural hospitals. The Medicaid cuts are leading to staffing shortages, reduced services, and economic strain on local communities. Also, there's different solutions that because the rural areas are being hit harder by this, but clinical trials are also having trouble recruiting participants due to the immigration and visa hurdles impacting medical research No one's talking about this. Okay. This is really truly happening. And then there's the ripple effect of reduced services, longer wait times, and local jobs that are being impacted. I know in the community that I live, the healthcare model is the highest employer in the county that I live. So clients need assistance in this complex environment. That's why you're here. That's why I'm here as a sponsor. That's why knowing a little bit about the changes that are going on are so important. So the strategy is the enrollment, working past age 65, COBRA, HSA, Medigap, drug costs. These are the strategies around Medicare. But there's also the annual plan reviews. People need to know that formularies will change, networks will change, and clients can't really review these on their own. You can go onto a website and get lost. You can go into Medicare.gov, and that's a little bit better. But it's nice to know that they have a resource, objective guidance. Again, we get paid by the insurance company. Our services are no cost to anyone. People love that. Planners, CPAs love the fact that we are a resource and extension of their value. The IRMA exposure. Income decisions must be made 2 years before. This is advanced tax planning, whether it be RMDs or Roth conversions, capital gains, business sales. All of these impact their IRMA exposure. Even though people shouldn't really make their decisions based on IRMA, people get really upset about this IRMA component because you can see they can pay $700 a month for Part B and Part D income adjustment if they've made good money. So again, this is the estimate: 315,000 for healthcare in retirement for a retired couple. That includes dental, hearing. Costs are often underestimated. Long-term care risk. 70% of Americans over 65 will require some form of long-term care eventually. Some people are happy to have their family help out. There are programs around Alzheimer's. There's a guide program. There's support from the government on some programs, whether it be Parkinson's or Alzheimer's. But families are caregivers. There's a lot of money involved in that. And caregivers, there's less of them out there that are willing to go to people's homes. So that's a risk that people have. And then I spoke earlier of appeals and claims. Denied claims and coverage disputes are increasingly common across all coverages. And clients struggle to do this work on their own. So again, I covered this up front because I wanted those of you who are listening to understand the real impact for your clients. And I'm going to go into some other pieces. I've still got good time, and so the rest of this is often what I've covered in other presentations. And I will be at MAP for anyone who would like to sit with me and chat there as well, one-on-one. And love to do presentations for your team as well. But the average cost for healthcare in America is $11,000 a year for every man, woman, and child. We spend $4.5 trillion on healthcare in the United States, which eclipses the gross domestic product of many third world countries. It's a lot. But the next two pieces are important. 50% of all medical costs in America are for pre-diabetic insulin care or medications. That just shows how important that is. That shows why GLP-1 medications have made such a difference. But so much of the absorption of those costs are not just for the consumer, it's for the insurance companies, especially those group insurance companies who are approving it. They're having trouble with approvals, whether it's sleep apnea or it's diabetes or heart issues. More and more are being accepted, but it's still a struggle because companies are, hemorrhaging with the costs associated with these medications. Poverty accounts for 60% of all healthcare costs in America. So again, the big beautiful bill is set to address it. More people are going to be using hospitals who don't have any coverage at all. 63% of people age 65 and above consider healthcare to be their number one concern. And it's truly, again, I'm, I'm a big fan of education, and I think that people just need to understand their current plan and choices as they move into Medicare, or even decisions they make if they're under 65, looking at the Affordable Care Act, even currently. So most new and existing enrollees, they worry that they will get this important decision wrong, and certainly that's why we are here. So Medicare, no different than health insurance, is different for everyone. As people turn 65 and retire, it introduces so many different healthcare options. But people need to compare their group coverage that they have to their retirement coverage to Medicare. So that's what I do. That's what my team does. We look at your current plan. We look at plans that are being offered in retirement. Some companies offer great options. Some companies offer very poor choices. And then there's Medicare. And so all of them need to be looked at as a whole to see which is better for yourself, your spouse, your family, um, to decide what's next. But the premium cost as an employee could be different than the premium cost for a spouse. Are there savings? That's to be determined, but it's certainly something that people look at their out of pocket maximum as a key piece, and look at their deductibles to see how quickly they get to those numbers. People are in good health and they're getting their premiums paid by their health, their company, stick with it. But people who are using their coverages a lot with either a high premium or a high out of pocket maximum, it's time to at least look at it. But that transition to retirement, right? What is it that you want to do? What is it that you need to do for your family or for your health? And depending on the state that you live in, I mean, Massachusetts is a very flexible state, but it's different than Rhode Island or New Hampshire. Um, so, there are different state rules that allow people to change plans more readily. But that transition to retirement, having what's called guaranteed issue, meaning that no matter what your health is, you can get the best plan in America, may not always be there. So getting guaranteed issue when you're first eligible for Medicare or when you're retiring and you have credible coverage greater than 20 employees, then you have that decision to make. But these coverages vary by state and sometimes by county. And so, based on when people move, um, or whether they have two homes, all these things are part of the discussion. And so, each year, people have to evaluate their coverage. That's what we're here for, but that's what people should be doing anyway. On a group plan, people are being given three new choices going into the new year, and they have to opt in and opt out. And come the end of the year, people are often calling us saying, should I stay with my group plan or should I move to Medicare? Is this the right time? When am I going to retire? What's my deductible? What's my out of pocket maximum? All these pieces all come into play because health insurance is different for everyone. So part A, hospitalization, part B, everything else outpatient services. So the durable medical equipment, the diagnostic tests, the specialist, all part B. And again, I'll talk again about the premium, but part A, for anyone who's worked or their spouse has worked for 10 years or 40 quarters in the United States, part A is free. But there are people who are coming from other countries who want to pay into Part A, and they can. Um, but if they have the 40 quarters or 10 years, it is premium free. But original Medicare doesn't cover everything, folks. Certainly the things that I've highlighted are the things that people ask for all the time: routine dental, eyeglasses and contacts, hearing aids. The truth is these advantage plans, which are the HMOs now, some PPOs are left. They do include a little bit of routine dental, a little bit of eyeglasses and contacts, and some of them include hearing aids. But all of these other pieces are not covered by original Medicare. Some of these are covered by long-term care insurance. Some of them are just private pay. But the advantage plans used to offer over the counter, used to offer, in some cases, some acupuncture. And so a lot of that has changed based on all the things that I've talked about here in this webinar. So is original Medicare automatic? Well, the answer is both yes and no. If you are collecting Social Security of any type at all, you'll automatically get your A and B card at 65. But some people are working for a company of greater than 20 employees and they don't need Part B or don't want Part B because they like their group coverage. This screen, this conversation is at least half of my day because this is where people, the rubber meets the road. This is when people are concerned, am I going to get a penalty for not getting Part A? Should I return my Part A and Part B card because I don't want to pay for Part B? If you're collecting Social Security, the Part B premium is going to automatically come out of your Social Security check. Many people never noticed it. And so getting Part B at the right time is important because it could be $203 a month. It could be $600 a month, depending on how high your income was. So if you don't want to start on Medicare Part B, but you are collecting Social Security, you need to reject Part B by signing the back of your card. If you're 69 years old and ready to retire and you have Part A because you went ahead and got Part A, now it's time to enroll in Medicare Part B. Remember, unemployed, self-employed, or working for a company of greater than 20 employees, less than 20 employees, excuse me, you have to get Medicare A and B. Okay. Medicare needs to be primary and your group coverage can be secondary, but you can also get a Medicare plan that may or may not save you money. This is one of the two forms, a request for Part B. You already have Part A. So this form plus this form, which is a verification from your employer that you have credible coverage. I talked earlier about a gap of 2 months. They weren't working. They had no coverage. And so very tiny penalty. Okay. But people who have multiple jobs past age 65, they need multiple forms of this um, that they need to save and utilize someday when they go on to Medicare. Um, so this is the full chart. Remember, above 109 and above 218, there is this premium adjustment. And so married filing separately, especially when I'm talking to CPAs, married filing separately is really not encouraged in the world of Medicare premiums because it goes from a 203 all the way to 649 if somebody's married filing separately. I have had people amend their returns because, of course, they didn't realize it. So again, this is the chart and this is important. But the thing that I want to show you, which I alluded to earlier, is this life-changing event form. This has helped save people thousands and thousands of dollars. CPAs and financial planners love this opportunity to help people save money. The life-changing event up top is what you would click off. The life-changing event, let's call it retirement, let's call it work stoppage, let's call it divorce or marriage, whatever it may be. And then you estimate your current year's income. So if they worked for the first 6 months of the year and then all they were getting is Social Security, their income dropped by 20% or whatever it may be, then they fill this out and they submit this. We fax these forms as a courtesy, but this is the form and they will adjust the Part B premium. So even if you are lowering at one bracket and then maybe in 2027, you're lowering in another bracket, you can fill this out in subsequent years. So this isn't a penalty. This is just a surcharge. But again, it's looking back 2 years prior's modified adjusted gross income. So that's what they're charging people for. But if they have a life-changing event like retirement or work reduction, they can actually fill this out and get it reduced. Excuse me. So initial enrollment period, it's the 7-month window. That's when the mail will start. That's when the phone calls will start from any insurance company or from brokers or agencies because they want to get you onto Medicare. Well, but if you're working for a company of greater than 20 employees and you like your coverage, there's nothing you need to do. Can you get Part A? Yes, if you want to. But many people say, you know what? If I don't need to do anything and you're assuring me that I will not get penalized, then I can just do this later. But many people, I'd say 75% of the people I work with get Part A just to have their card, tell their friends, their neighbors, their colleagues that they have it, and they have it. The annual enrollment period, that's the period of time that's the most crazy for us, and that people are reevaluating their plans. They're looking at their prescription drug plans. They're looking at maybe switching from one Advantage plan to another or changing carriers in any sort. So that's the window that exists. But there's also an additional window that very few people know about. It's January 1st through March 31st. This is when you can change from one Advantage plan to another. You go to the doctor's office, the doctor says, I'm sorry, I don't take this plan. They go, well, and many health facilities know about us, and they'll say you need to call them and see if there's a carrier that will cover us. And so they can still change through March 31st. They can also change to original Medicare in that 3 month window. So that's something that is really helpful for many folks. But the special enrollment period, this is for people who are retiring any time of the year. So if you're retiring at the end of June and you want to start July 1st for Medicare, you have a special enrollment period. You also have special enrollment periods if you're moving out of the state or the county. Then there's also enrollments, special enrollments for FEMA related activities like fire, hurricane, any of the things that occur across this country. So different insurance companies based on different counties offer special enrollments for people to be able to make a change mid-year. We can't guarantee it, but there's certainly enough disasters in this country that they do come up fairly regularly. Keeping it simple, folks, and I've got 10 minutes or so, and I do want to try and get to questions. So people have four choices. They can either stay on their employer group plan or their retirement plan. And I will review their benefit summary to see if that's the best solution. Again, I will always do what's in the best interest of the client. Again, our services are free. I help many, many people, and I say stay the course. Unless they change the premiums or they change the benefits, stay the course. And that works well. Original Medicare, 80% only, A and B only. There's no prescription drug coverage here, and there's a 20% exposure for everything. So this is dangerous, but some people want it because they can go to any doctor that takes Medicare anywhere in the country. Med Advantage, 65% of all people in America own a Med Advantage plan. And it's not that they're choosing the Med Advantage plan particularly, it's that the companies that are offering retirement packages are going towards a Med Advantage model. So people say, I don't want an Advantage plan, but my company's paying for the premium. Well, that's a tough decision. Now, in most cases, the out of pocket maximums are low. So these are good plans, but you are in a network. So Med Advantage plans, again, PPOs are going away. The HMOs are more popular these days. It's important to know that all your doctors are covered by the network. But this is when people can save a lot of money. These Advantage plans, at least in the open market, not the corporate market, these are premiums of zero per month, $30 a month, and you get, co-pays for everything, but you have zero premium. As opposed to these Medigap plans, these Med Supplement plans, that depending on the part of the country you're in, it can be from $75 a month to $400 a month. So New York, Connecticut, Massachusetts, and Maine have higher premiums because people can switch from an Advantage plan to a Medigap plan without any health questions, underwriting, or pre-existing conditions. Because of that, folks, the premiums are higher. So for now, these carriers are allowing people to come into these better plans without any health questions. But the Advantage plans for many people in those four states are places for people to start to test it out. There's a lot of bias against these Med Advantage plans, and I have 1,000 or more people on them. And in the states that I mentioned, they know that they can switch. If they have a bad year, they still know that they can switch. So as much bias is out there, especially with the case managers and social workers and hospitals that I work with, they often say, don't sell my client an Advantage plan. But the client has to make their own decision. I don't spend anyone else's money. And so the Advantage plans are very affordable. If any of you or your clients don't have chronic conditions, it is certainly something to look at. But people with means or want to have peace of mind, certainly Medigap plans work very well and is the answer. But on the Med Advantage plan, it includes a prescription drug plan at no additional cost. You still pay the copays. On the Medigap plan side, you have to have a standalone prescription drug plan that needs to be evaluated each year. If somebody's looking at an Advantage plan, we get a list of all your doctors, we do all the work, and we tell you which carriers work for all of you. Med supplement carriers, you know the top line carriers. It's the bottom line carriers you haven't necessarily heard of. And there are many more, again, especially in Massachusetts, that are, you know, carriers that have been around a long time. But the fact is that carriers are coming into the market, and that's where the bait and switch comes in. So, and then there's also what's called the high deductible plan. This is sort of where I'm going to start to wrap up a bit. Is the high deductible plan is more cost effective these days than ever. Let me explain. Is that for a low premium, let's call it $90 a month, as opposed to let's call it $300 a month, you have a 20% coinsurance up to a yearly limit of $3,000. So you have $1,000 service, Medicare pays $800, you pay $200. You have a $500 service, Medicare pays $400, you pay $100 until you get to $3,000. Same doctor access, same flexibility in that regard. So these high deductible plans are working much better. Again, a $3,000 maximum out of pocket based on a 20% co-insurance, but much lower premiums. Again, in the states that we talked about, Massachusetts, Maryland, Connecticut, and New York, you can switch from this plan to a better plan in subsequent years. The prescription drug market is by far the biggest challenge that we face because people's medications are incredibly challenging and expensive. Every year this changes. The deductible is $615 for 2026. That's only for brand named medications, not for generics. So if somebody has brand name medications, which is called tier 3 or tier 4 or tier 5, according to Medicare, they have to pay this $615 based on retail in the first few months. And then their price goes down. So the pharmacies matter, where you go as a preferred pharmacy or standard pharmacy. But the last thing I'll mention is that there are other resources. There's GoodRx, there's Cost Plus with Cuban and Trump, there's the Canadian Med Store out of Florida, there's Amazon, there's Needy Meds. There are other options. And as you see from this chart, there are prices on medications that you're all familiar with that have been discounted based on negotiations that have gone on. So there's a lot of work being done on prescription drugs. It's really critical. Okay, I'm going to go to the last two slides. I want to make sure that everyone understands, and I hope this has been valuable, is to recognize the importance of knowing your plan's potential costs. Look at your plan, see the benefit summary, understand it a little bit better than you did yesterday, but also the importance and integration of healthcare costs and financial planning. It's a component and it's a big cost potentially. Advocate and appeal. It's in bold letters because it's so true and people aren't also doing enough of it. Seek objective information. Identify a trusted Medicare resource. But during AEP, October 15th through December 7th, we put people on our mailing list. We send them educational information. We do webinars all the time for the consumer. If you see any of mine and you want to forward it over to your clients, please do so. Evaluate the doctors and the medications. That's what we do. That's what they need to do. Understand the difference between Advantage and Medigap. Tell a friend. You're the CPAs, financial planners, post the review. So you deserve a Medicare expert in your corner. We provide education. We provide client support. We have a team of 7. We work alongside you as tax and financial planning experts to make this happen. So that is my presentation. And so I hope this was valuable. And I look forward to seeing you all soon up in Massachusetts and or at MAP. Thank you.